My lecture today is exercise science. Unfortunately, it's one of those like broad range topics. I don't know if that's good or bad. So there's a lot to kind of talk about. So I don't really go into anything in particular in too much detail. However, I try to hit every little point just because a lot of the time these are part of the test taking questions and definitions and stuff like that. So it is kind of important that we do talk about the small, annoying, boring stuff because a lot of the time it's tested. Mm. Why is the header not showing? I don't know if people could see my header.
No, we don't see the header. It's just blank. Just black.
Okay, so that's kind of weird. Let's see if I close it, it'll. Oh, okay.
I don't think you had a header for that one.
I guess not. So types of exercises. There you go.
There you go.
So there's something wrong for a second. So isotonic exercises, it's force constant through range of motion. And that's kind of like just lifting weights or free weights. Isometric, the muscle length is proportional to external load. So you're pushing on a wall and the mall isn't moving, so your muscles like maintaining a specific length, and this does cause hypertrophy of the muscle. Concentric contractions is when your muscle and tension proportional to the external load, so you're actually shortening the muscle fiber, so you're contracting the muscle. And then eccentric is when you're extending that bicep curl and your bicep is lengthening through that range of motion, so the force remains constant as the muscle lengthens. And this is the most efficient method of strengthening muscles and tendons. So that eccentric um is very important for those two things. And then a lot of the questions also ask you what causes the most likely risk of injury, and it's that eccentric contraction. That's when you build the most, and that's when you risk the most. So no pain, no gain type of thing. So if you're willing to risk it and you're lengthening the muscles, that's when you give it a chance of also getting hurt. Continuing on those types of exercises is isokinetic. So muscle contracts at a constant load with varied resistance. You need specific equipment for that, so like a Cybex machine. Just because it's kind of hard to replicate that. You can't really do that with free weights. I feel like remember the Bowflex? I don't think it's as popular anymore, but as the kind of like those bars bend, the load changes throughout the cycle that you're exercising. So those can also, I feel like, work as an isokinetic exercise. Plyometrics are going to be rapid, eccentric, concentric contractions. So shortening, lengthening, like box jumps, burpees, all those type of exercises. Open chain exercises is talking about the where your lower extremity is, whether it's in air or if it's planted. So open chain obviously is your foot or your arm isn't planted to something, and so seated leg extensions and curls. Obviously, those have their pros and cons, but it's important to understand those because if you're repairing an ACL, you don't want your patient doing an open chain exercise. You want them to be closed chain, and you want to be able to describe that to your patient so they know what they can and what they can't do because you can't watch them all the time. Close chain is going to be less risky, obviously, especially for, again, patients post op. And the distal end of the extremity is fixed. So squats with a planted foot, leg press machine, and so on and so forth. I mean, a lot of this is just common sense, just looking at the name, and it kind of explains it by itself. However, they're just good reminders. Moving on to anaerobic versus aerobic exercise. So anaerobic is when your energy production um, kind of it gets used up faster. So it's going to be an intense physical activity, then you can keep up with the energy production. Let me kind of put it that way, is how I kind of think about it. So intense physical activity for a very short duration, fueled by energy sources within the muscle and independent of the use of inhaled oxygen as an energy source. So your muscle is you're benching 200 pounds, your body can't create enough energy to maintain that force. So you're tired, you tire those muscles out, you build lactic acid, you get that type 2 muscle, that fast switch activation, and that's usually 10 seconds of high intensity exercise. And then you move to that glycolytic because you can't keep up, you burnt that anaerobic energy up, you move into that lactic acid, as I just mentioned, low ATP yield, lactic acidosis after several minutes, and 2 to 3 minutes of exercise. If you're able to maintain energy creation with the level of energy expenditure, that's your aerobic exercise. Activity that uses large muscle groups that can be maintained continuously in rhythmic in nature. Muscle groups activated by this type of exercise rely on aerobic metabolism in the form of ATP. So it's oxidative phosphorylation, back to that biochemistry in pre-med. You have high ATP yield. It requires oxygen and it has type 1 muscles, slow red muscles, and it's usually your endurance exercises, you're running, you're cycling, you're swimming, those type of aerobic exercises where you're losing using large muscle group and you're able to generate enough ATP as you exercise. Obviously, the more you exercise, the more efficient these metabolisms become. So that's also very important and why exercise is one of the things that's good for you. I was trying to look at like all this data, whether anaerobic versus aerobic, which one is healthier for you. So do you weight lift or do you run? And the data obviously is all over the place. And usually in general, you just say like, hey, you should be doing all of the above. You should weight train, build some muscle. You should do anaerobic exercise or aerobic exercises, running for your cardiovascular health. One of the studies says they have equal protection against cardiovascular events. I don't know how good that study was. I was just scanning them because there's so much data out there. But again, it's important that you do both of these types of exercises and change up your programs. For the type of exercise programs you could do, there's periodization. So this is planned variation in intensity and duration. And the fundamental concept is you're gradually progressing from high volume, low intensity to low volume, high intensity to prepare an athlete for peak performance. And the way I kind of explain that in my head is a patient that's going to, or not a patient, an athlete that's going to go and run a 100-meter dash. When he first starts running, he runs a mile or two, and then he slowly picks up the speed and shorten the length of the run. So eventually, he has the best peak performance, and that's a type of that type of specific exercise. I think it was developed in the 1970s, but by a Russian scientist or somebody from there, and they were training for those types of stuff. And obviously, weight training, the best and the only type of training, even though I just said you should do everything, is muscle training. Increases cross sectional area, strength, the mitochondria within the cells, the capillary density. It improves connective tissue and it causes muscle hypertrophy in adults and increases muscle firing efficiency in adolescents. And so that's an important concept. So kids can strength train. Obviously, you want to be careful, good form, good technique, all that stuff. You don't make them hurt themselves. You're not going heavyweight, but that efficiency is going to improve. They're not necessarily increasing the size of the myofibrils. In an adult, you're born with a certain number. You just can increase its size or cross-sectional area. You can't increase the number of muscle fibers that you actually have. You make them more efficient, you make them larger, you increase the blood flow so you could exert them for longer. So those are all the things that you could kind of do. Moving on, aqua training. This is also one of the great training exercise forms, and this is causes or the benefit again is you're in the water, so you have decreased joint stress, you have buoyancy helping you, you're preventing secondary injuries to the lower limb. Suppose a patient has a fracture in their lower extremity and you want them to train, but they're non-weight bearing. Depending on the level of water, you can estimate how much weight bearing they're actually doing. So if you're up to their neck, you're protecting, I think, 90% of their weight. If you're up to their waist, you're at 50% weight bearing. So you could start patients who are 50% weight bearing much sooner with their treatment options um, and get them moving and doing some sort of cardio without risking injury and so on, and I think that's if you have that available, it's a great resource. You have increased cardiorespiratory fitness, less abrupt increase in heart rate, increased oxygen consumption. The only negative that I was looking at is you have decreased bone density. Obviously, if you're not loading your bones because you're more buoyant in water, theoretically, if you're in the water long enough, you're not going to, maximize your bone density, as well as in other forms of training. When you load your bones, they remodel and can get, thicker. So specifically in weight training, when you're in water, you're not taking advantage of that type of benefit when you exercise. That's just something to know. In endurance training, your results in change in circulation and muscle metabolism. The muscle adapts by increasing energy efficiency. You increase the mitochondrial size, number, and density, similar to weight training. Increase in enzymes involved in the Krebs cycle, fatty acid processing, respiratory chain, and increased use of fatty acids over glycogen. Again, you want to be able to burn those fat stores, because you have more of them stored in your body. And over time, oxidative capacity of all the muscle fibers increase, percentage of more highly oxygenated 2A fibers increase, and you're improving aerobic and anaerobic lactic thresholds. So you have more anaerobic energy stores available, and then you're better at metabolizing and generating oxygen or ATP for other energy sources for that aerobic exercise. Again, all this training improves, has multiple benefits, and increases muscle size and efficiency and stuff like that in different ways. Muscle injury, again, you have muscle soreness, edema, and inflammation. Usually, this is eccentric exercise. Again, that eccentric exercise is so important to kind of know. Honestly, whenever I would take a test question, I wasn't sure. I would always guess eccentric, and most of the time it's correct. You peak 24 to 40 hours at soreness, and elevated CK levels can be noted. Muscle strain is usually at the myotendinous junction. Again, can occur at eccentric contraction, or, well, not again, it can, but it most commonly occurs at eccentric. And then for healing, inflammatory phase is then followed by fibrosis, and that's important. Muscle atrophy can occur for multiple reasons, whether it's disuse or nerve injury, fatty infiltration, increased fatigue, which causes increased fatigability. Muscle crossing is single joint atrophies faster because it's less likely to be activated or used if you're sedentary. And muscle held in its shortened position also atrophies faster, and that's something to note. So, for example, somebody has knee surgery, they're locked in extension, their quads are going to atrophy because they're shortened faster than their hamstrings or their calf muscles, because those are held in a lengthened position. So, that's also something to note. Muscle contusion, it's non-penetrating blunt injury, again, leads to inflammation and hematoma. The extracellular connective tissue forms within T days and peaks between 5 and 21. You get scar formation, variable muscle regeneration, and you can get myositis ossificans, and you could get that HO, and most apparent 4 weeks post injury. And again, the classic test question is you get a thigh contusion from a helmet and a football player, and you want to hold that in a flex position. So all these are clinically relevant as well as very highly testable subjects. Muscle laceration also can occur most commonly in the myotendinous junction. You get an abnormal muscle contour that heals by dense connective scar tissue, and it's mediated by myofibroblasts. The TGF beta stimulates differentiation and proliferation of those myofibroblasts, and then regeneration and reinnervation is unpredictable and likely incomplete. Again, when you have a laceration, it's a more complex type injury because you have disruption of those fibers, as well as, you never know, do you have a direct nerve injury, do you have a vascular injury, all of that needs to be addressed accordingly. For immobilization, muscle strength rapidly declines during immobilization because of the decrease in muscle size, in tension per unit of muscle cross sectional area, and it results in fatty infiltration. So, for example, when patients have a chronic rotator cuff tear, again, that's kind of like immobilizing the muscle because you're not really firing it, or you try to and it's not really working, and it slowly atrophies more and more and more. And then there's obviously a grading criteria for that. And the muscle fatigability also increases rapidly after limb mobilization. So obviously, if you're not as strong, you're going to fatigue quicker. You're not as efficient. So all those all tie in. And muscles within limbs fixed by plaster casts have lower levels of resting glycogen and ATP use, and more rapid depletion of muscle glycogen and ATP during work. That's when you activate them again after immobilization, and greater increase in lactic during work and decreased capacity to oxidize fatty acids during work. So, again, all the benefits of exercise are reversed, or actually just using your muscle. And the greatest loss of absolute muscle occurs at the beginning, and then it slowly slows, or goes down. So the first week of immobilization is going to be the biggest decrease or you see the worst amount of atrophy, and then the amount slows down. And this is seen actually at the cellular level and loss of myofibrils within the fibers. So immobilization, obviously, whenever you're treating somebody, you want to balance that with risk of re-injury slash healing. But the less you can immobilize, the less risk you have of all these negatives, as well as stiffness. So you want to get your patients moving and doing stuff. In general, with any type of treatment, you want decreased inflammation, increased local blood flow, and increased tissue compliance. And there's multiple different modalities to get to that. So obviously, basic, rice therapy, hot or cold treatments. There was a 32 study meta-analysis, and it talked about cold and heat, and how controversial it can get. Do you use hot or cold? I'm sorry, for the first 24, 48 hours, and then you use heat. This looked at heat and cold early and late, and actually found cold therapy within 1 hour of exercise can reduce pain levels as good as analgesic effect, and after exercise, it had no obvious effect on reducing level of pain in patients more than 24 hours. So cold only helped acutely and not late, and actually heat helped in the beginning as well as late after 24 hours. So somebody has an injury, you don't just ice them. You can do heat. It is still appropriate because it helps acutely and with late pain. Then there's massage, obviously, that can make sense. That's an option. And then ultrasound, the way that works is it causes tissue healing by raising the temperature of normal levels by a few degrees, and by increasing temperature, you get vasodilation, you get increased blood flow, and you get hopefully increased healing. There's so many different ultrasound techniques for different things, for a bone stimulator, all those types of stuff. And then the amount that you use it, the depth of the radiation, all that stuff varies depending on what you're trying to treat, as well as the treatment like type, or like the machine. For electrical stimulation, that's also an option. And they've looked at frequency, pulse width, modulation of pulses, amplitude, electrode placement, frequency, and all the different patterns that you could pulse electric stimulation through the muscle. And there's so many different studies. I just mentioned there's a lot of variability. There are some standardizations that you could look up. I don't have them recalled, even though I just read them a few days ago. But there's different systems that use different pulses, and so on and so forth. So overall, the idea is you want to improve muscle strength, blood flow, atrophy healing, and decrease pain by stimulating that muscle to contract. Whether you have a nerve injury and you're not able to contract it, or you're immobilizing an extremity and you still want to use those muscles, that's when you use electrical stimulation. And the negative is it's uncoordinated, it's inefficient movement rather than like a normal nerve signal that your nerves are carrying. So there's arguably not as much benefit as actually firing. I mean, obviously, there's not as much benefit as firing the muscle yourself. However, it is an option when you are limited in what you can do. Ionophoresis is when you're using currents to drive medication through the skin into deeper tissue. And that's also another treatment modality that you have. Again, it's not either or, it's what you do in conjunction with each other to help benefit your patient to the best of your ability. I feel like that's what good therapists do. You send them, they do whatever they can in whatever modality they have available to them. Unfortunately, some of these tools can be expensive, so that's just something to keep of note. And that's all I got for you guys today. Sorry if I rambled a little bit. It is a long subject with a lot of different things to kind of hit. I trying to talk about a little bit from each different point.
No, that was a nice job. There's a lot of stuff, we go through these lectures and all of us will get tested on it. We know it for a lot of our board exams, and you guys will all get tested still on this topic. But if you actually, get down to it on a granular level, it's actually really important when we educate our patients on kind of rehabilitation protocols and exercise. I call it the exercise prescription, right? You're diagnosing and giving patients a tool and an outline on how to exercise properly, and they have all these questions. And I think, and hopefully, more of our patients are becoming more educated in the fitness and wellness space, and so it's really important that we stay on top of some of these basic terms that a lot of our patients are becoming familiar with. So that was a nice overview, hitting a lot of the important points there. So well done. Any other comments or questions? Okay, I think we will move on next. I think Dr. Sardelli is going to give us a talk next. You ready?
I am ready.
Awesome. So you just take it away whenever you're all set.
All right. Let's see. Um, all right. Just a quick check. Are you guys able to see the screen?
Yep, we can see it.
All right. Perfect. Figure out how to view this thing.
Yeah, I think you just go bottom right there on that slideshow. If you go down, um,
Is that it?
yeah, there you go. Perfect.
All right. Perfect, guys. So, um, this is a new lecture for me this year, and I hope you guys find it beneficial. I would love feedback. Um, when I was in your shoes, it was sort of new to me to be out in practice and then depend upon a variety of radiologists reading my films. And, we get the benefit of having the patient in front of us and can see, um, their symptoms. We can do a physical examination, but then you get this MRI in front of you. And sometimes what you're seeing doesn't necessarily corroborate with what the MRI shows. And so you sort of have to start to be able to read these things yourself, at least at a very basic level, to figure out if what you're seeing is the same as what other people are seeing, and if you guys can agree or disagree. So with that, I'm just going to go over MRI of the knee. If you like the talk, I have an MRI of the shoulder as well, that we can go through and kind of go and learn a little bit about the shoulder. We could do that different year or this year or whatever. But if you don't find it beneficial and you're like, I already know MRI and we get it from radiology colleagues, feel free to say that this lecture was stupid. So anyway, when looking at the MRI, I think you want to have a systematic approach. Look at the menisci, the cruciates, the collaterals, some bone marrow changes, cartilage, the patellofemoral compartment, muscles, tendons, bursa, and then everything else. And so I've kind of stayed true to this approach. I look at the MRI sort of systematically. I'll start by looking at the meniscus, the cruciates, the collaterals. I'll look for bone marrow edema changes, cartilage problems. And then I'll kind of scroll through the patellofemoral compartment to see if there's anything I can find there, muscles, tendons, and then bursa, and then anything else I might see. The standard sequences that you're going to get pretty much at any of the radiology places around town, and certainly I think across the country, you're going to get coronal T1s and 2s. You're going to get sagittal proton density and T2 they'll oftentimes angulated along the ACL. The radiologists find that to be helpful. And then you'll get axial proton density with fat SAT images. So starting with the menisci, the meniscus should be black on all sequences. It sort of looks like a bow tie at the periphery. It's triangular cross section, and then it moves centrally. So here's a view of normal meniscus. It's got some signal in it, but it certainly doesn't extend anywhere. The medial meniscus, the posterior horn, is larger than the anterior horn. It's a C-shaped meniscus, as we know. The lateral meniscus, the anterior and posterior horns are of equal size. It's got more of a closed curvature than the medial meniscus, so it's almost more circular. So if you're going to diagnose a meniscus tear, or if the radiologist is going to diagnose a meniscus tear, you need to see high signal extending to an articular surface. So as you see here, there's a lateral meniscus tear. You see signal extending from the meniscus down to the inferior articular surface or towards the tibia. It's got to be seen on at least two images in the same, or it could be in different planes. You could see it on a coronal and then a sagittal. T1 and proton density are higher sensitivity than T2s. And then you can also look for displaced meniscal tears. So what about a displaced fragment? If it displaces into the notch, we oftentimes see it as a double PCL sign. Fragments can easily be overlooked on the MRI. Here you can see a displaced fragment into the notch. I sort of highlighted that with the arrow. Sometimes you see it extending posteriorly. This is a displaced meniscal fragment. Here's another one up into the notch. So displaced fragments can also go anteriorly. If you see sort of a diminutive posterior horn, The torn fragment can be flipped anterior. So here you see a flipped posterior horn segment anterior. It's called a double anterior horn sign. Be sure not to get confused with the popliteus tendon. But you can see here these flipped segments. So beware of that if someone's complaining of loss of range of motion, certainly catching, locking, etc. Discoid menisci can be common. They're usually seen with a mid-zone greater than 11 millimeters. They can tear at any age. They're obviously congenital. They're more common in the lateral meniscus. So here you see 3 consecutive views, even into a 4th and 5th view here of the lateral meniscus that doesn't necessarily come to that C shape towards the midline. And so that is how you would diagnose a discoid lateral meniscus. The most common area of tearing of the discoid lateral meniscus is actually anterior. So they tear these anteriorly, but then they can extend into the mid body and then posterior. That was a question on my boards. I don't know why it was, but they tend to tear anterior first. Radial tears typically seen in only one plane. So here you see a radial tear, medial meniscus. You'll see truncation of the meniscus around the tear, and fluid will separate the fragments. What about a parameniscal cyst? It can be large. Sometimes they'll come to you and you can actually palpate a mass on either the medial or lateral aspect of the knee. It's oftentimes nice confirmation that you do have some sort of subtle tear to the meniscus and the joint fluid is collected within this parameniscal cyst. Pitfalls when looking at the meniscus. So oftentimes the anterior horn of the lateral meniscus can have a fibrillar appearance. And you have to remember too, there's an anterior intermeniscal ligament that is a distinct entity separate from the anterior horns. Posteriorly, there's the meniscofemoral ligaments, as well as on the lateral side, there's the popliteus tendon. Remember, don't read any one image in isolation and follow the structures sequentially. So when you guys are on service with me, we'll go through our MRIs and we'll really scrutinize them to see and make sure we're not missing something. And more importantly, that we're not thinking we see something when it doesn't actually exist. So here's a normal anterior horn of the lateral meniscus. Multiple fiber bundles are separated by intermediate signal. Don't mistake this for a tear. Here you see the anterior horn attaching normally. You might have your radiology colleagues, sometimes they'll say, well, they've got an anterior horn lateral meniscus tear. And as you kind of roll through, you'll see, I don't really think this is a tear. As I look here, this seems to be a normal attachment of the anterior horn of the lateral meniscus. Here's a great example of the intermeniscal ligament. So you see this distinct structure. I don't know if you guys can see my cursor, but that's the anterior intermeniscal ligament. And so that's not a tear. That's not a tear between the anterior horn. But again, with a fibrillar appearance of that anterior horn plus the intermeniscal ligament, I've seen in my practice, and I'm not sure if others have seen this, a lot of times you'll get radiology reports, they have an anterior lateral meniscus tear. Just always be wary of that because this is normal to find these types of things. What about the popliteus tendon? Again, follow it. Here we see it starting low. Here we see it directly behind the posterior horn of the lateral meniscus, and then it coming up to attach up onto the femur there. So this is not a tear of the lateral meniscus. This is a normal popliteus tendon near the posterior aspect of the lateral compartment. Clinical mimics of a meniscus tear. Again, cartilage injuries can present as meniscus tears, bone bruises, MCL injuries. So, and then what about recurrent tears after meniscectomy? So here again, you see a displaced fragment, you see a horizontal tear in a previously operated on knee. Recurrent tears are often difficult to see. Normal meniscus may have some signal going to a surface. You can use gadolinium, so you can do indirect arthrography, or oftentimes we'll do gadolinium type MRI. So we'll do injection or arthrograms. After 20 minutes, a capacious joint will contain fluid. Fluid will go into a recurrent tear. So if I'm concerned about recurrent tearing of a meniscus after somebody's been operated on, I'll oftentimes ask for an MRI with dye. It's just more sensitive. What about the ACL? As we know, it originates on the lateral aspect, medial tibial spine, inserts posteriorly at the lateral femoral condyle. Two bands. It's extra synovial but intracapsular. It prevents anterior displacement of the tibia. Associated injuries can be MCL, PCL, meniscus, LCL injuries with Sagan fractures, posterolateral corner injuries, lateral femoral impaction type injuries, cartilage injuries, and bone bruises. So here's an example. About 41 to 68% of acute ACL tears will have an associated meniscus tear. So oftentimes when you're evaluating these young athletes, whether it's in my clinic or I think Dr. Frush is on the call, it's in his clinic, always be on the lookout for an associated meniscus tear because they're more common than you think. 81 to 91% of chronic ACL tears have meniscal tears. And that's defined as someone with an ACL tear over 3 months old. So, and then of course we can remember O'Donoghue's unhappy tribe, an ACL, medial meniscus, and an MCL. But these are less common than the more acute lateral meniscus tears that occur in the acute setting. So here's the MRI of an ACL. The bands are low signal. They're separated by fat. You must see fibers throughout their course, and you must see attachments in all planes. Okay, so here you see the ACL attaching to the tibia and to the femur. So sites of an ACL tear, they can be mid-substance or they can be avulsed off the femur or the tibia. Here's a mid-substance ACL tear, fairly straightforward to see. You see loss of fibrous continuity, high signal on T2 weighted images. This can be a variable finding. What about a tear off the femoral attachment? High signal at the attachment is best seen on a coronal or axial image. I like this saying. Sometimes you'll see these ACLs that really look flat. The ACL that's supposed to head up to the femur ends up heading up this way. And we say Earth to Pluto. It goes kind of to outer space. It's not really going to the femoral attachment. It's just kind of hanging out here, headed up in this direction. Or if we see it later and it falls down, waters of Babylon, it lays down and weeps. So it's just sitting right here laying down. It's not going to its normal attachment up here on the femur. You can always use a coronal to verify a tear. Here you see in the center, there's just no ligament left there. What about secondary signs to assist you if they don't have an obvious mid-substance tear or an obvious avulsion? You can see a posterolateral bone bruise. You can see an impaction or bone bruise at the lateral femoral condyle, a Sagan fracture, buckling of the PCL, or a drawer sign where you see actual anterior displacement of the tibia on the femur on MRI. Bone bruises, again, no cortical disruption, but you see signal here near the sulcus terminalis where there's been a bone bruise, and then you see it posteriorly here at the tibia. Again, it's usually linear or stellate, excuse me. It's usually with an ACL tear. And again, you see the two sites here where you'll get those types of bone bruises. Here you can see a bone bruise versus actually an impaction fracture. Here you see the cortex is almost being disrupted. So this is clearly a large pivot shift maneuver where you don't just get a bone bruise, but you actually impact the bone and it actually compresses. So this is a sign of, again, an ACL tear, an indirect sign, but this is a little bit more of a violent type injury than just a bone bruise. What about a Sagan fracture? Here you see it on plane radiographs where you see an avulsion here off of the tibia. It's an avulsion of that lateral joint capsule. Here you see it on MRI. Again, a lot of signal in the subcutaneous tissues, and you can see there's been a disruption here at the tibia with bone that's extended and been pulled off. Again, consistent with a Sagan type injury, an injury to the lateral capsule, and an association with an ACL tear. Here in the middle, you see the ACL is absent. Here's a case example of an ACL tear. Here you see again, just that mid-substance disruption. You see some fibers still attached here at the tibia, but then really nothing. And then some residual fibers up here at the femur. And again, here you just don't see any sort of attachment coming up here to the femur. Also in this case, you can recognize that, again, in the acute setting with an ACL, you'll often get a lateral meniscus tear. Here's a flipped portion of the lateral meniscus flipped anteriorly. You see an absent posterior horn of that lateral meniscus, and you see diffuse bone bruising here at the lateral tibia and lateral femur. Here's another case example where you can see a meniscus tear, but then an associated chondral lesion here, and again, an ACL that's been torn. So I don't know if anybody wants to volunteer for this one and list 3 injuries that they see on this MRI. Anybody want to take a stab at it? If not, I'll just tell you, this isn't meant to be a pimp session.
Oh,
So
I was just
ACL.
about to chime in and just pick
Oh,
someone.
sure. Go ahead.
Or how about the fellows do it together? How about that? We'll make it
All right. Go for it, guys.
I can chime in and take an easy one. I think it looks like there is a little bit of tearing in that ACL mid substance.
Right here.
Yep.
Good. Boom. Right
And
there. Got it.
my next one was going to be the lateral meniscus. Looks like there's an
Boom.
intersubstance tear.
And you see that tear extending to an articular surface. What about the medial meniscus? Do you see signal extending to an articular surface?
Not all the way through, I didn't think.
No. So there's no medial meniscus tear, in my opinion. I see a mid-substance ACL tear. I see a lateral meniscus tear. And this is something we haven't really covered yet, but is there something else you see where there's signal that might suggest an injury?
You're circling it, so I'm guessing around the MCL there. So yeah, probably the extra fluid kind of in between the medial condyle and the MCL.
Yeah. So this is an athlete that presented with an acute mid-substance ACL tear. They had a lateral meniscus tear and an MCL sprain. So again, I felt comfortable saying to family, in reviewing this, the MRI was called as a PCL sprain, complete disruption of the ACL, medial and lateral meniscus tears. And again, I said, I sort of respectfully disagree with the radiologist in this one. I do think your daughter injured her knee. I think she has an ACL tear. I definitely think she has a lateral meniscus tear. She also has an MCL sprain, though, and I think we're going to start with some physical therapy. We're going to get her into an appropriate brace to allow the MCL to heal, and then we'll have to come back and address the other pathology that we see. But I just wanted to highlight this to see if you guys could pick up on
This is Stephen Bluey.
What's that?
I think it inadvertently his microphone got on. It's okay.
Oh, okay. Sorry.
Yes,
Yeah.
sir.
So yeah, so this is one where we kind of walked through the MRI together. And again, I think if you guys can start to recognize what constitutes a meniscus and then some of these other injuries, it can be really helpful to your practice in case you're getting reads from radiologists that you're either unfamiliar with or that you don't know if they're MSK trained or not. So what about MRI post ACL repair, reconstruction? You're going to see low signal bands from the osseous tunnel to the femur to the tibial tunnel. So here we see the post reconstruction ACL. I see fibers throughout. So I'm thinking that this is a successful ACL reconstruction. So if you get an MRI too soon, and what I mean by that is sooner than say 3 months, the ligament can oftentimes be difficult to see because there still may be a lot of fluid in the knee. But what about the torn graft? You'll see fluid within the graft, you'll see laxity of the graft, and you'll see an altered course of the graft, right? And so in this instance, this is a graft this is an ACL that's torn. I see signal up here that and kind of absent fibers where the tunnel was drilled. We see laxity here as well. What about an incorrectly placed ACL? What about one that's too vertical? Here we see this is where the tunnel is. It's sort of up high here. The graft looks like a mess. And so again, incorrectly placed ACLs, you're going to see it's effectively going to impinge and it's going to fail. This is a common one. And unfortunately, I see this in my practice. This is the athlete that's, presents with stiffness after their ACL, right? A cyclops lesion. And here you see the cyclops lesion right here. There's your graft. And then you see this little bit of scarring here in the front, right? That's not meniscus. That's a cyclops lesion after their ACL reconstruction. And they'll say, I'm still struggling, doc, with extension. It's painful. It hurts when I try to go into extension. And you get an MRI. Your graft is okay, but you have, again, here, you see it. You have this focal area of fibrosis. We call that a cyclops lesion. So be aware of that for all of us that are going to be doing ACL surgeries. You can find those. What about the PCL? Moving on. It originates at the posterior surface of the intercondylar region of the tibia. It inserts on the medial femoral condyle. It's usually wider, thicker, and stronger. It's got uniformly low signal intensity. It forms a smooth arc. Here you can see it. It restrains posterior displacement of the tibia. It can stabilize you from excess valgus or varus force, and it resists internal rotation. What about the meniscofemoral ligaments, the posterior horn of the lateral meniscus, and it extends up towards the femur? It can be in front and behind the PCL. So here you see your PCL, and here you see one of the ligaments right here. It's often intact even when the PCL is torn, so it can be difficult to distinguish. Here are the MRI findings of a PCL tear. High signal abnormality is always abnormal. Here you see a stump of PCL and then just kind of nothing. Here again, you see this rounded stump of PCL, again, not making it to the femur. Full thickness tears tend to be mid-substance, but they can also be avulsions off of the femur or tibia. Here we have the ACL is intact, but here you see the bone bruising pattern of a PCL injury, right? And here's your avulsion of the PCL. So oftentimes medial femoral condyle. And you'll see anterior tibial bone bruising, most typically with a PCL tear. So you'll see a sag sign, bone bruising, posterior femur, anterior tibia. It's opposite of the ACL. What about the MCL? Again, 2 layers, superficial and deep. Valgus force, we can grade them out. Complete, high grade, and low grade. They're usually associated with meniscus tears, most likely medially, and they can be associated with ACL and PCL tears. So here's an example of a complete MCL tear. We see it attaching onto the femur, and then all of a sudden we see the ligament abruptly stop, and then we see a stump down here on the tibia. What about the posterolateral corner? Again, it's a complex of structures, the popliteus tendon, the posterior capsule, lateral capsule, and the head of the fibula. Usually there's posterolateral pain. There can be buckling into hyperextension with weight bearing and instability. The causes can be a varus injury or a hyperextension injury with external rotation. And again, it's associated oftentimes with cruciate ligament injuries. How does the IT band insert? Here it is. It inserts at the Gertie's tubercle. Deep fibers can insert on the distal femur, and it's uncommonly torn. What about the FCL, though? That's obliquely oriented. You have to see it torn on successive images. Here's your FCL right here. Tears are best seen on axial or coronally T2 weighted images. Here you see an FCL tear. Again, going back, here's your intact FCL. Here's where you can see a tear. Here it's coming down, and you just see there's not anything up here anymore. You see it completely torn away. What about the popliteofibular ligament? It attaches to the fibular styloid and popliteus tendon. It can be torn in isolation. What about the biceps femoris? I should say, here's your popliteus tendon. Here's a disruption of your popliteofibular ligament. What about the biceps femoris? It attaches to the lateral aspect of the fibular styloid. It's uncommonly injured. Here's an example of an intact biceps femoris. Here's a biceps femoris that's now torn, part of a posterolateral corner injury. What about the popliteus muscle? Again, it starts on the posterior surface of the tibia and attaches up onto the popliteal groove on the femur. It's associated with posterior horn lateral meniscus tears, and it's rarely torn in isolation. Here you can see an example of your popliteus here. Here's an example of the popliteus being torn and absent in the setting of a lateral meniscus that's intact. That brings us kind of to knee dislocations now that we've covered ACL, PCL, MCL, posterolateral corner injuries. Again, these can be common skiing injuries. You can get bicruciate injuries, motor vehicle accidents, multiple ligaments torn. Here's just some examples of what that might look like. Here you can see, again, no PCL, no ACL. Here on this image, you can see the MCL has also been torn. And you can almost see that the femur is subluxing medially because of the significance of the MCL tear and the bicruciate injury. Moving on from that, we can talk about cartilage and how they present on MRI. Again, they can have non-specific pain. Cartilage injuries typically present with a joint effusion. So again, if you've got somebody in your office that's got a persistently swollen knee, you're looking for something different than what the radiologist might be looking for, because again, you've got the benefit of the patient in front of you. They can have joint line pain and it can cause locking occasionally. So fat suppressed proton density images or gadolinium enhanced T2 images are usually the best. Now that we have 3 Tesla MRI, sometimes you don't have to add any dye. They are so good. And I'm not sure at the DMC or some of the outlying clinics where you guys rotate if you have access to a 3 Tesla MRI. But if you do, utilize it because it's oftentimes much better than a 1.5 Tesla image. So again, you'll see focal high signal intensity in the cartilage. Remember, it varies in thickness. And then magic angle can cause spurious increases in signal when it's oriented 45 degrees to the magnetic field. That's similar to what you'll see for the rotator cuff, where we know the fibers take an oblique turn as they insert on the greater tuberosity. And you'll see signal in the rotator cuff, but no tear. We call that magic angle due to the way the fibers orient in relation to the magnetic field. But here you can see cartilage fractures. Here you see an intact meniscus, and you can see right here that gray stripe of cartilage becomes disrupted here. Here again, you can see cartilage off of the patella. Here you see all the multiple fragments, and this is the zone of injury. Here you can see sometimes loose bodies. This is obviously a knee effusion, and then you can see a loose piece of cartilage floating in the suprapatellar pouch. What about an osteochondral fracture? Again, here you see it going through the cartilage and then causing this blooming artifact into the condyle with an associated disruption of the cortical line. Sometimes you'll see flaps of tissue, but it goes through the subchondral plate. And then osteochondritis dissecans, again, classic presentation, a young male patient, lateral aspect of the medial femoral condyle. Can be seen symptomatically at any age, but again, we know that to be the site of congenital problems. About 50% will report some sort of knee trauma. You can stage them. This is the Burton-Hardy classification: cartilage injury with bone marrow edema. Number 2, bone fracture but no separation. 2A is cystic changes. 3 is a separated fragment, and 4 is a free floating fragment. There's other staging options. This is one that works pretty well when you're just reviewing MRIs to see what they have. Here's the MRI of an osteochondral defect. Here you see the cartilage is absent. Again, you see that blooming artifact into the condyle and a breaking of the subchondral bone. What about when you see semicircular subchondral fractures? Here you can see right here. This is an osteochondral defect, but again, the cartilage appears intact over top, and I don't see any fluid that goes necessarily around it, or at least penetrating through the cartilage layer. I see some signal over here. So this is maybe a cartilage injury at risk, but it's not loose. Sometimes you can see cyst formation. Here you see a 2A cyst, and then you see a stage 3 with fluid actually behind the fragment. This is indicating that it's loose. So you see here, You've got this cyst in the bone, and now I'm seeing fluid behind it. This is a 3. And then, of course, 4 is when you see the free floating fragment in the knee. What about the patellofemoral joint? You can see cartilage injuries, tracking abnormalities, patellar dislocations, patellar tendon injury. So patellar dislocation can be a twist, a valgus injury, or a direct blow. Oftentimes, these are people that'll come in and they've already spontaneously relocated, so they don't necessarily give you a history of a dislocation because they said, I felt a pop and something was weird, but then I popped over again. So patellar dislocation and relocation, you'll see injury to the medial retinaculum. You can see an avulsion. You can see lateral patellar tilt. You can see a contusion to the lateral femoral condyle. You can see an osteochondral injury to the medial patella. And here you see blood in the joint. You can see here this fluid blood signal here. So here's an example. You see the bone bruising at the lateral femoral condyle here, and you can see the MPFL has torn off of the medial aspect of the femur. So that is your patellar dislocation and relocation, that classic lateral femoral condyle bone bruise. And sometimes you'll see a bone bruise at the medial patella as well. Patellar alignment can often be viewed when you're looking at plain films. MRI can be helpful for TTTG, that sort of thing. Gun sight CT scan, probably better than MRI to assess rotational abnormalities. This is just an example, again, not necessarily for MRI, but here you can see clearly a hypoplastic trochlear groove with malrotation of the femur and patellar, instability. Continuing with more MRI, this is a popliteal cyst. We commonly see these. Can be a sign of what we call internal derangement. I hate that term, but it's what the radiologists like to say. Popliteal cysts are often associated with some level of cartilage injury or arthritis, right? The joint is making fluid and it creates a cyst. It goes between the gastrocnemius and the semimembranosus. And so you see it right here forming at the posteromedial aspect of the knee. They can dissect inferiorly. Here you can see one that's burst and is going down the calf, and it can present like a DVT. So be aware of the patient that's got calf pain, that's never had surgery, never really had an injury, but just say, my calf hurts. It can be a medial calf strain, but it could also be a ruptured popliteal cyst. So in summary, you can find common clusters of findings. Beware of red herrings. And just make sure you're having a checklist so that you can go through like we just did on meniscus, ligaments, cartilage, and ultimately cystic changes. Thank you.
That was great, Dr. Serta. That was really comprehensive. Honestly, for all the fellows and residents that are on, that was it's going to be probably the best lecture you see on knee MRI. So I really liked how you explained all those findings. It's very difficult, especially when you get out. There's going to be always conflicting reads, and it's not, we're obviously not picking on radiologists here. They're only getting one view. We have the clinical context there to really help narrow our view. So, but it serves as a reminder there to really read all of your MRIs, to do yourself a service when you guys are starting, and just really pay attention to looking at all those images, and then just trying to correlate some of the findings, because there's also times obviously that we'll miss stuff and the radiologist will pick it up as well. So yeah, it was very, very comprehensive. It was great.
Oh, thanks, Brandon. Yeah, and I would echo your sentiments because again, if you find a radiologist that you like and that gives you good reads, that's even better, right? Because they're going to find things. We're not trained on this stuff. We're just trained to correlate our clinical findings with the picture. And so if you find somebody that's great, they'll find things that you don't see. And then you can actually have an intellectual conversation with them on the phone. Like, they have lateral joint line pain. I can't figure it out. And then they look at you and say, I think I see a ruptured popliteus tendon. Did you look at that? And you're like, nah, I didn't see that. So anyway, it works both ways.
Absolutely.
I do have a question. You talked about the sometimes normal appearing like not abnormalities, but sometimes can be misread as tears. What would be the next step if you have someone that you're still on the fence with? Is that where you do more of the arthrogram? Any imaging modalities that you could go to after?
Yeah, great question, Kyle, because this is the conundrum of most of us that are taking care of athletes or patients in general is they become fixated on the read, right? Well, doc, it says here that I've got a partial thickness bursal-sided tear of my rotator cuff, and you're looking at it and you're saying, I just don't think there's anything here. There's signal in it. I'm sorry, I'm jumping to the shoulder. Let's use the knee. It says here I've got a meniscus tear. Sometimes you're disagreeing on principle, right? Like it's a degenerative meniscus tear. They've got arthritis floridly throughout the knee. And you're saying, I just don't want you to fixate on your meniscus tear because I think the bigger picture here is the fact that you've got arthritis. If you've got a definite difference between someone calls, let's say something really different, they say that you've got a PCL tear and you're saying, I don't see it. The next move for me would be to get a dye study because I think that would definitely allow for dye to show and leak through the ligament if it was indeed torn. So for me, moving to some sort of arthrogram would be my next step. But you're going to see that common clinically is it's not just the radiologist that you're kind of looking at and seeing what they see versus what you see and correlating clinically, but it's the patients that come in with just their MRI read in hand saying, doc, it tells me that I've got a medial meniscus tear. And you're looking at it and saying, I just don't see it. An arthrogram is certainly helpful in that situation.
Thank you.
Awesome. Any other questions for Dr. Sardelli? No, that was great. That was great. Honestly, we probably need to do that for every joint throughout the year. So
Yeah,
we'll see.
well,
If you did so well, we may have to steal you for these other ones.
Yeah, if you want to do shoulder, I'm happy to provide. Like I said, if you found it useful, sometimes it's one of these things where you're like, I don't know why we're talking about radiology.
No, this is so useful for everyone. This is great. No, the shoulder would be great.
Yes, we
Okay.
definitely appreciate the shoulder.
I would
All
like that. Yes, please.
Okay, sounds good.
Awesome. Perfect. Well, I think our final talk for the day is one of our alumni, Dr. Lauren Green. We're very excited to have her back. Lauren, you ready to go?
I am. How do I think I have to.
Oh, I got to make you. Okay. I was not the host before, but I have to share. Sorry. I will do that. Okay. You should be all set.
Okay. Do I have to hit share or anything? Do you know?
Yep. At the bottom. Just that green button.
Okay.
There you go.
All right. Good?
Yes.
Okay, let me just close this. All right, so I am a 2020 graduate. I'm currently practicing in the Lansing area in Grand Ledge. Doing mostly primary care sports, probably like 90% sports, still doing some family med. I'm in a private practice, which is kind of unique. So if any of you guys like have questions about kind of doing private practice and doing sports, feel free to email me. You can get my email either from Dr. Keikos or from EJ, but happy to help navigate if you guys have questions. So we'll get into this. So just exercise in pregnancy and especially in the postpartum period. I felt especially kind of going into practice, especially still doing primary care. It's a huge gap in care for these patients and these athletes. So we'll kind of get into that. All right, no disclosures, unfortunately, no financial disclosures. So where are patients getting their information? Blessing and a curse, of course, social media. It's something that we have to kind of be mindful of. I mean, most of our patients, especially from a pregnancy standpoint, what to do exercise wise. They're getting their resources online. Their OBs, again, kind of have limited knowledge in terms of exercise medicine. So we just have to be mindful that they're getting a lot of this stuff elsewhere. So what are the current recommendations? So ACOG really doesn't have anything new aside from 2020, but in 2020 they came out kind of with their blanket statements of what is recommended. So in the absence of any contraindications, they deemed exercise safe in pregnancy, beneficial in pregnancy, and in the postpartum period. The kind of blanket goal, same as what we recommend for the average population that is not pregnant, 150 minutes a week of moderate aerobic activity and strength training. So we want to spread that across the week, so across 7 days. In terms of aerobic strength conditioning, again, before, during, and after pregnancy. In terms of what does moderate aerobic activity, what is that, right? Your patients are going to ask you, well, what does that entail? Because for me, moderate might be obviously very different than it is for them. So we used to use heart rate monitoring a lot. We're trying to shift more, and you'll hear this kind of mentioned, the talk test, right? Well, what does that mean? I mean, it should be that they have exercise. During exercise, they should be able to hold, a decent conversation. And it's, again, a perceived exertion, right? So we say it should be somewhat hard. It shouldn't be like the hardest workout of their life, but of course, that's going to be different for some of the elite athletes. And again, this is the 150 minutes is just your standard kind of regular pregnant person who's asking advice on exercise. What was interesting is in 2015, ACOG shifted their guidelines quite a bit. And right after that, they just did a general survey to see, how many of these patients are actually abiding by, what are they actually doing day to day in terms of physical activity. And they found that only 45% were actually meeting the current guidelines of the 150 minutes. So that means over half your patients really aren't even meeting that in terms of just basic aerobic exercise. And out of those 45%, only 11% were doing any time of like strength or weight training. Again, mindful, this is 2015, so 10 years have passed. These numbers have probably changed significantly, especially trying to kind of make it a little bit more aware of the safety of exercise in pregnancy, but just something to kind of keep in mind. A little flash back to the 80s. I mean, 1985 was the first ACOG guideline. Obviously, you can see here drastically different from what we have now. Basically, if you didn't exercise, definitely don't start now. They didn't want to do, if you were previously active, okay to do it, but just reduce the amount to reduce fetal harm. So again, very different than what we see now. So what about your high level athletes, right? This needs to be very much individualized. What I tend to stress to all my pregnant patients, especially those in, high level, again, what's considered high level. I have anywhere from, most of them that I would consider high level are those doing Ironmans or kind of ultras that are training excessively. I do try and stress that it needs to be a multidisciplinary care. So, of course, from their obstetrician, they need to be seeing them, but they need to continue seeing sports med throughout their pregnancy. I mean, these are patients that typically in the primary care world, we're only seeing them once or twice a year, especially if they're healthy. We see them for their annual wellness, right? But from a sports med standpoint, like we really should be seeing them every trimester because things change drastically. Trying to get PT on board, and we'll go through a lot in terms of like pelvic floor therapy, doing it, throughout pregnancy as well as postpartum. And then, of course, from a nutritional standpoint, having a nutritionist on board. What we want to stress to them a lot is kind of watching for any changes, right? Watching for any overtraining, excessive heat, dehydration. I mean, common things that you'd think of. In terms of high impact collision or contact sports, my blanket statement to most of them is just it's not recommended. Of course, you can take this case by case, but for the most part, it is not. What are the concerns with this subset of athlete? There is really limited literature on this in terms of like a direct correlation, but you will see some papers out there that mention potential relationship with high intensity training and small for gestational age, preterm delivery, of course, cervical insufficiency, and then the nutritional side of things. Is there any type of, is it adequate in what they're getting during their pregnancy? Of course, being mindful as this applies to all athletes, just the changes that occur that increase our risk of injuries, the joint laxity, pelvic floor diastasis, shift to gravity, and then the cardiovascular change. Taking a history, like anything in medicine, so important, especially in this case. So getting a pre-pregnancy training history, because that's going to be really what helps individualize their plan going forward, and you helping them decide kind of what training needs to look like in the next few months. So what about just kind of your heavy resistance training? So these are your CrossFitters, your more recreational athletes, of course, those that are weightlifting or weight training. This tends to be a big bulk, probably most of our patients that we're seeing, especially in the primary care setting. So this was an interesting study back from 2022 looking at specifically heavy resistance training during pregnancy. They looked at just almost about 700 individuals and basically saw there was no increased risk of either prenatal, perinatal, delivery, or early postpartum, any type of adverse outcomes versus kind of the general population. So kind of keeping that in mind when we're counseling patients. What was interesting is this study kind of noted, you will have a lot of patients kind of hear things, especially again, social media in that third trimester, should I still be lifting as heavy? Should I still be doing things like I was, my first and second? This study kind of highlighted something that showed that those that continued training until their delivery at their pre-pregnancy training level actually had fewer reproductive complications versus those that kind of either reduced or stopped training in that third trimester. So kind of reinforcing, there's no adverse kind of effects that we've seen if they felt okay, obviously modifying as needed to continue training up until delivery. This study has a ton of limitations. It's observational, it's self-reporting, so of course, ton of room for bias in there. It's mostly, of course, you're relying on experienced athletes here, not beginner weight trainers. So of course, less risk of injury, etc. And there's no randomization here, right? So there's no non-lifters that they compared it to. It's purely just observational, but just interesting to kind of note here. I think the key point here is really just having some flexible guidance in terms of what we're advising these patients to do, especially in pregnancy. So in general, right, there is a ton of gaps and research that's needed in the world of just pregnancy in general and physical activity, especially in the subset populations of those that have multiple, so twin pregnancy, triplet pregnancies, those with preeclampsia, even gestational diabetes. These are subset groups that most of the time we say, okay, you're higher risk than the average pregnant person, maybe we should limit you. We just don't have the studies on it. The other gaps that we see are really just what is optimal, what type, how often, the intensity, the frequency of the exercises. There's just not a lot of good literature out there. The elite athletes, again, I mentioned one, small study there, but again, few high quality studies. The same with the resistance training athletes. But other thing too, right? Your extreme endurance athletes, extreme heat, altitude exposure, just very limited data on that. And trying to kind of come up with a standardization of what is this moderate intensity? What can we get better at defining this for patients? So what are some of the benefits of exercise in pregnancy? I mean, some of these we all know they're pretty straightforward, but lower incidence, of course, of gestational weight gain, but kind of most importantly, reduce risk of both gestational diabetes and gestational hypertension, therefore potentially preeclampsia or eclampsia. We do see reduced risk of C-sections and operative vaginal births with exercise. In terms of, shorter labor, shorter recovery, improved postpartum recovery, the verdict is still out on that. There's no, again, good statements or good articles really saying that 100% that's the case. From a mental health standpoint, same thing. We can't say for sure that it's going to decrease the risk of postpartum depression, but we definitely know that it improves psychological well-being of the mom. So we can assume that, probably some improvement are less likely to have postpartum depression. So physiology during pregnancy. I mean, of course, for boards and things like that, you probably need to know a little bit more in terms of detail of like how much is that stroke volume changing. And remember, from a cardiovascular standpoint, especially, that's going to change every trimester. But I mean, putting those numbers aside, really what advice how does that change for your athlete, right? It's good to know those numbers, but when a patient's asking you like, okay, well, what do I need to look for? So from a cardiovascular standpoint, right, we know that with the output increasing, their heart rates increase. So their workload during pregnancy is going to be higher. So especially the athletes that are tracking, I mean, most of us are using some form of a Garmin or Apple Watch, right, to track our heart rates. That max heart rate is going to be different than it was pre-pregnancy. Renal filtration increases, so of course, more increased risk of dehydration. Blood volume increasing, so postural changes, right? So going, especially your power lifters, something to keep in mind. It's not that they're out of shape, it's just kind of these physiological changes that they should expect to see during pregnancy. From a respiratory standpoint, oxygen delivery is modified. So of course, exercise demands are altered. Again, you're not out of shape necessarily. You've been working out through your whole pregnancy. It just, demands are higher. And another thing to keep in mind, it's harder then to compensate for the metabolic acidosis that naturally happens during pregnancy. From an MSK standpoint, connective tissue, relaxin, estrogen, those play a huge role. We'll go into those in a sec here. But they increase joint laxity, of course, then increased risk of stability, falls, etc. From a gut standpoint, slower motility, increased risk for reflux, GERD, and then from a metabolic standpoint, increased metabolic rate and metabolic demand. So what are the musculoskeletal changes happening in pregnancy? Really what we care about, right, in the sports med world. Weight gain, naturally, right? That's going to happen. The joint laxity, increase, SI joint, pubic symphysis. We'll see increased risk of ACL tears, ligament instability, gait changes, of course, postural changes. And a lot of this is in response to hormones. So we stress always relaxin, right? We know relaxin increases laxity, but you'll see, so relaxin is that blue, kind of dark blue marker through here. You see it peaks pretty early. So it's peaking just right before the end of the first trimester, and then it kind of levels off. But then you'll see kind of estrogen, right, takes over. And what this graph doesn't show, which is probably one of the most important things in the postpartum phase, is that estrogen green line goes all the way up and it just drops right off. So those change in hormones that we see kind of during pregnancy with the laxity, it doesn't necessarily, just because the hormones drop off, is not necessarily meaning it's all going back to normal. Those things can persist for, weeks to even months afterwards. So what are some of the other musculoskeletal changes? Again, things that we, mostly know to look for. The change in the lordosis in the spine, that increases obviously as the trimesters go on, and then we start to see an anterior kind of forward tilt in the pelvis. Sometimes you'll see a little bit of a posterior tilt, but something else especially I've kind of run into, especially with my runners, is the feet change. So kind of being mindful and kind of, even warning them about some of these changes that can happen. Of course, feet swelling is one. But what happens is they start to get a little bit more of a relaxed arch. So they start to either pronate a little bit more, the feet seem flatter, they seem wider. So some of them, of course, have to change kind of their shoes. or the way that they're lacing their shoes. So something just to keep in mind. So what are the big things to avoid? I mean, hot environments, hot tubs, saunas, hot yoga, things like that. Similar effects to fevers, right? Increased risk of neural tube defects, complications, preterm labor, etc. High altitude scuba diving, any type of contact sport, skiing, of course. And then basically, I always say something that's just out of your norm, something that you typically don't do, maybe don't pick up doing while you're pregnant. So some of these absolute contraindications to exercise, again, these are things probably going to be, told by the OB, but something just to keep in mind. Hemodynamically significant, any big heart disease, restricted lung disease, of course, if they have any type of cervical incompetence, or if they have a cervical cerclage, of course, they're not going to be recommended to be exercising, at least high impact. Important here. So just because they have a multi pregnancy doesn't necessarily mean they have any contraindication to exercise. It's specifically those with high risk for preterm labor, again, determined by their OB. Any history of vaginal bleeding during this pregnancy, placenta previa, preterm labor, ruptured membranes, et cetera, et cetera. So what other type of modifications we should have our patients be doing during exercise? A lot more kind of education out there now, but this is something that typically I'll provide a handout to my patients, even during family planning discussions in the office, if they're athletes or even if they're not, just kind of giving them a basic handout of some pelvic floor work they can start to do at home. That's easy to do. And I really stress the importance of doing it during pregnancy, because if you catch these patients postpartum, it's just much tougher to treat. And a lot of it can be avoided. So really having them focus on kind of core engagement, looking for any coning. So that's what you see in that top picture there. You want to avoid all of that because it increases the risk of pelvic floor insufficiency and, of course, diastasis. There's a lot of focus on diaphragmatic breathing. There's a ton of YouTube videos out there showing them how to do a proper diaphragmatic breath and how to incorporate that into their exercise and their workouts. And then, of course, just being mindful, of course, their body's changing, right? So trying to adjust any workouts accordingly, and that's going to change from week to week even sometimes. So common injuries we see, of course, right? Back pain, ligament injuries, increased risk of carpal tunnel, de Quervain's, you'll hear mommy wrist, right? During pregnancy and postpartum, suprapubic dysfunction, pelvic floor, like we talked about. Important to note, pelvic floor dysfunction is not always because of weakness. Sometimes it can be from those muscles being too tight as well and not and being kind of worked incorrectly during pregnancy. So something to keep in mind, and where pelvic floor therapy can be helpful, especially in the postpartum phase, diastasis. And then from a mental health standpoint, just of course, just not being able to exercise as much. So diastasis. So traditionally, in terms of if we're looking at diastasis and in the postpartum period, women wanting to get this fixed, it has traditionally been deemed cosmetic. More and more, we're kind of seeing the effects of this long term that's far beyond cosmetic. So there was a good study that came out back in 2024 looking at just over 400 patients, postpartum patients. And what they did was they used ultrasound to measure the intra-rectus distance. And what they were looking at is kind of the long-term outcomes related to that: low back pain, urinary insufficiency, quality of life at anywhere from 3 to 30 years postpartum. And what they saw was if we saw more than 3 centimeters of a distance in that rectus distance, we saw patients complain of severe back pain all the way up until 10 years postpartum. Poor quality of life they would report, and then higher incidence, of course, of even umbilical hernias up to 20 years. Of course, to make note, I mean, at 20, 30 years postpartum, it was statistically non-significant. I think at that point, a lot of that comes into if you've been dealing with this for 20, 30 years, your quality of life just is not as impacted just because it becomes kind of your norm. But something to kind of keep in mind. This is not cosmetic. If patients mention it to you, there is, some data showing that the long term can affect functional and pain. All right, so let's jump into the postpartum period here. So postpartum care here in this country is very limited, right? Again, something we're trying to shift, but don't know how well that's going, because it seems like it's pretty much been the same for quite a while here. But the ACOG recommendations is there needs to be some form of contact with your OB within the first 1 to 3 weeks postpartum, and then a comprehensive follow-up. Usually standard is about 6 weeks, but they have technically, they say up until 12 weeks postpartum. I know for me, at least, delivered in 2 different states, it was pretty much the same. A 2-week virtual visit. Hey, how are things going? Good. Okay. Any calf pain? How's your mood? Good. Okay. See you at 6 weeks. So very limited, right? Even the comprehensive visits. I mean, we have to remember the OBs are OBs, right? They're not sports medicine specialists, as the same for us, right? When they're coming to us for sports med, we're definitely not OBs. So the knowledge in terms of clearing them back for activity is like, okay, you're 6 weeks postpartum. You can, and you can see in the bottom corner here on the right, they say actionable guidance on resumption of physical activity. And that's if, of course, you have no incision pain, no uterine insufficiency, fecal incontinence, pelvic floor, do we need pelvic floor PT? But they don't really give much guidance, as they really don't have the knowledge and aren't really expected to. So it's something we kind of need to try and educate a little bit more in the primary care sports world, kind of how to guide these women. What was interesting is in 2018, ACOG came out with, trying to redefine the postpartum visit, right? And that's where kind of these components came from. But what they found about 40% of women don't even attend their postpartum visits. So the question about returning to sport or returning to activity at 6 weeks, we're probably missing a lot of them. So the most up-to-date guidelines that's out there is actually the Canadian guidelines, which came out in 2025 in the spring. But what they recommend is early return to light intensity post-birth. They don't really set a time. They don't set 2 weeks, 6 weeks. But what they do recommend is, from that 150 minutes per week pre and during pregnancy to 120 of moderate vigorous activity. And that includes, again, aerobic and strength training. In terms of pelvic floor, I typically encourage my patients to do it all through pregnancy. And I give them typically an adjusted workout or kind of exercise list of things to do in that early postpartum phase. And that's typically, I tell them to start it at even 1 week postpartum. And this is by no means strength training. I mean, they're not working out. It's simply working on breath work, trying to re-engage the core. But it's daily pelvic floor muscle training to kind of reconnect those muscles and really to kind of help them long term. Of course, they say limit sedentary time to less than 8 hours. Don't sit for more than 8 hours a day. If you think of a woman who's nursing, I mean, you're nursing typically every 2 to 3 hours. And at that phase, especially early postpartum, you're going to be sitting for 45 minutes to an hour. So 8 hours is kind of easy to get to unintentionally, without even thinking about it. So just being mindful of that. Especially if they're nursing, making sure they're getting adequate hydration, and then obviously monitoring for any lactation issues, especially if you're still doing primary care. For the elite athletes or those that are doing high intensity training, something to be mindful of is the effect of bone health. And we'll talk a little bit about this a little later here, and then energy availability. And there is increased risk for REDS in this group, just because the level of activity and the demand that it takes, especially if they're nursing. So what are some of the contraindications to exercise postpartum? Severe abdominal pain, if their hypertension is still uncontrolled. So these patients that had preeclampsia or even just gestational hypertension during their pregnancy. Any type of postpartum cardiomyopathy, that's going to be pretty much guided by cardiology and by their OBs. If they're still having any vaginal bleeding, any MSK issues, or any active infections. So what are some of the benefits? Postpartum physical activity, of course, mental health is a big one. We see typically about 45% reduction in exercise postpartum. Remember earlier we said we couldn't really for sure say that exercise during pregnancy doesn't decrease the risk of postpartum depression, but we do know being active in the postpartum period can reduce that and obviously help with mood. Urinary incontinence, as much as 37, almost 40% reduction. Type 2 diabetes, significant reduction there, and just being active. What's most importantly is that as long as they're okay and they have no contraindications, of course, to exercise, there is no evidence of increased harm, especially in those healthy postpartum patients. What I stress to all my patients is just really any movement matters. Of course, the goal is 120 minutes, but anything you can do, especially to kind of break up your sedentary time, just small bouts of movement can make a huge difference all around in just how you're feeling. And pelvic floor PT, keeping that in mind, of course, is there, nutritionists that we need, things like that. So some of the physiology that we see change is, the changes we saw during pregnancy, of course, they don't just stop as soon as, baby's delivered. So those cardiovascular changes, they take a few months, especially postpartum, to notice those changes in the heart rate, especially. Blood pressure can, peaks at about 3 to 6 days postpartum, but again, can kind of take a few weeks to normalize. Keep in mind, right? So you're especially postpartum or in that prothrombotic phase for a few weeks after. So anytime you see a woman early postpartum for any type of injury, be mindful of that, right? If they're coming in for an ankle injury or you're thinking, yeah, maybe you should put them in a boot, maybe something to reconsider, or putting them on some type of low-dose anticoagulation, aspirin, because their DVT risk is much higher. Of course, ligament laxity, that can persist, right? Like we talked about, the relaxin and the estrogen, even though those numbers drop off, those effects they have on the ligaments and on the body are not, immediately reversed. It takes a lot of time to rebuild. So trying to stress to especially the runners, right? Definitely focusing on pelvic floor strengthening, but kind of working up to back to your mileage that you were at. So pelvic floor rehab, right? We talked a little bit kind of here and there about this, but the prevalence in that first year postpartum for any type of urinary incontinence is up to 30%. And honestly, this is probably very much underestimated just from the conversations that I've had with patients. We have seen pelvic floor therapy again, right? Beneficial, not just in the postpartum period, but trying to catch these women, just working on, of course, they might not have symptoms during pregnancy, but trying to stress the importance of proper workouts, no coning, diaphragmatic breath, and strengthening things during pregnancy for less issues after. And again, right, for those that have diastasis, it's not just cosmetic. We do know that there's an effect long-term on physical changes, severe low back pain, quality of life, especially when it's pretty severe. So what about breastfeeding? We have seen no change really in milk supply with increasing exercise and getting back to normal exercise. Most importantly is being mindful of their hydration, calorie intake. All these things are kind of at high demand just with basic metabolic supply during the day. But of course, adding exercise, weight training on top of that, you just have to be mindful of that and kind of really trying to educate patients. Mastitis is a real thing. It can definitely happen more prominent as patients start to work out more, especially kind of bra choice and things like that they're choosing. And also trying to advise them to continue any type of supplementation, especially vitamin D and calcium postpartum. So what happens is, right, during nursing for breast milk production, your calcium is getting pulled from the bone. So of course, more susceptible to weakening and then of course fracture. Same thing with the estrogen, right? In this country at 65, most women get a bone density scan, and that's because most of them are postmenopausal. Well, postmenopausal, we see a drop in estrogen, again, increased risk of fractures, osteoporosis. Same type of idea. Of course, we're not looking for osteoporosis, but just be mindful. I mean, I've seen athletes, even non-athletes, kind of just roll their ankle and have kind of just the weirdest, oddest fractures in those first postpartum months. Just, because of the amount of calcium and weakening of bones that happen from the hormone changes. In the sports med world, just something to keep in mind. So the AAP does recommend nursing or breastfeeding up until the age of 2. So just being mindful of that when you're talking to athletes or you're talking to women in your practice, just asking those questions, are you nursing, right? Even if they said they had a baby a year ago, even 2 years ago, because it can change your, differentials a little bit, something to keep in mind. Biggest thing is just always ask, right? If you don't ask, then you don't know. All right. Any questions?
Oh, that was
That
great.
was great. Where's your conference? Or I'm sorry, your office?
I'm in Grand Ledge, so just west of Lansing.
Oh, sorry. I was just going to say, that was great. Those are very relevant topics, especially for our non-op fellows here. You guys will definitely be tested on. You'll get at least a couple of questions on your ITE, and definitely on your sports boards as well. But then obviously, academics aside, more just real life. Yes, I cannot stress enough the importance of maintaining an exercise regimen while pregnant. There's a lot of misinformation out there, Dr. Green, as you already highlighted. So I think it's really incumbent on us as sports physicians to really educate our patients on the importance of maintaining physical activity and not being fearful of activity. Even to this day, you get people that are worried about doing it, even just, having just increased abdominal pressure, and they're worried they're hurting the baby. I had a patient that came in the other day and I was like, oh my goodness, I was so worried. And she was only like in her first trimester, and she was worried that, she was doing an ab crunch and she somehow hurt the baby. So there's a lot of stuff that's out there that they're so worried and so protective, and rightfully so. It's a very stressful time sometimes, depending on the situation as well. So yeah, I think that you outlined it very well. That was great.
Question. So you have a patient that comes in for consultation just for like an exercise plan. Is there anything on physical exam that you specifically look for in this population, or anything different that you do during your exam?
So I definitely, like, if they're currently pregnant, you mean, or
Yeah.
postpartum? So
Yeah.
if they're currently pregnant and I know that they are working out, I'll have them do I'll have them do a crunch. I'll have them kind of bear down to see. That's really the only way to see if they're coning. So coning I mean, again, I think most people working out, especially that are, pretty active, you're elite, you're kind of high level athletes, they're kind of aware of this, but not necessarily, right? I mean, it's our job just to not assume that they know and just really observe. I have a few YouTube videos kind of saved, and I'll show them those in terms of what diaphragmatic breathing looks like, how to truly engage the core. And I just watch them do it, and I have them show me, and have them kind of show me how would you do, just because you're pregnant, it doesn't mean you can't do ab work. It just means we change the way you're doing things, and just really making sure you're engaging the right muscles. But, really, we look for coning and if they're able to truly like engage their core properly when they're working out.
Gotcha.
Anything else?
No, it's awesome. Thank you so much for coming back and giving that lecture. That was great.
Of course. Anytime.
Uh-oh, we're going to take you up on that anytime. You guys heard it. But I think that's probably it for the evening. Thanks, guys, for joining. Enjoy the rest of your evening.
Thanks,
Thank you very
everyone.
much.
Thank you.